once again, we are here to take some of the concepts that we speak about over time or have spoken about over time and put them together to show you how we can describe a method that may be somewhat common in osteopathic practice and describe how to do it well, right? So we've spoken in the past about the idea of a Stork stance or in a seated position with the patient seated and the practitioner having one leg on the table or one foot on the table, using their leg almost as an extra hand or a shelf. This can be done also essentially in a supine position. Bend both your knees. All right, so when using the legs as leverage, you can also use the leg of the practitioner. Preferably for balance, the down table leg is smarter, right? But you can use your own leg essentially as a support to help you get heavier leverage. Okay, so lift both your feet off the table, right? And just let your legs rest. So if you see that I ask the patient to lift their legs, it's so that I take work off of me and that I'm not doing all of the lifting of legs of any size. I want to remove as much load from me as possible. So you see my thigh is underneath the posterior aspect of his shin or his leg, aka the anatomical leg, below the knee, right? I'm underneath. Now, if you look at the length of his femur versus where I am in relation to the table with my knee and my shin and my thigh, we're not a good fit, right? There is space. So if I have him closer to 90, I don't even touch him, right? So I'm gonna have to rely on resting, right? Also, there's an angle to my leg, so he's automatically gonna slope towards me a little bit just because of the height of the table and the fact that my femur has an angle built into it. I want to talk about that just because you need to understand that in all of these positions, there are challenges built into them. There are not necessarily flaws, there are challenges and observable realities. Now, a position like this, a simple hold like this, is a great demonstration of contact is control. I have contact with his shins, I don't have any hands on him. I have contact with my thorax and my abdomen essentially on this leg, on the leg closest to me. Now I can have contact with my arm, with my other arm. There's a lot of variation. I'll take you through that. Now, as far as palpation is concerned, usually what you would see people using this for is the lumbar column. Now, to enact palpation or have a palpatory hand in the lumbar column, now I have to consider my size and how contorted I have to get, right? So I have to get in there. Now I'm in this position. So I'm in a much less advantageous position to control the lever, right? I can do it, I can do lots of things with it, but there's only so far I can move because I'm in a contorted position. Now if I stand up nice and straight, what I can do is I can recognize another concept of patient positioning where the table makes stable. So whatever is in contact with the table is essentially stable, so I can use it to my advantage. And this is where I can use multisensory integration. Keep your hands and your eyes on the prize, but where you can't keep your hands on the prize, keep your eyes on it. So I can use my eyes to judge motion dysfunction. Now I'm in a biased position. I am in a relative hip flexed position, which would lead to a relatively lumbar flexed position. But I can also, within this frame, find all kinds of motion dysfunction. Now, how might I go about doing that? I would use the leg, right? So now here is where being on one leg is a problem because it's hard to walk. I have to shimmy my leg and you can't see it. But I can come up to bind or whatever bind I think I feel or I see, right? So I can come into flexion, relative extension. I can create kind of side bending of the lumbar column in a relative sense, right? So if I go this way, this is fine. If I want to go the other way, I can't really do it. So to go both ways, this would be a better hold. So you see how I control the legs, there you go, and I can compare those visually. And also, because I have so much contact with the levers, I'll get a palpatory sense of what may or may not be going on. I'll get some signal, while it's a blunt signal, as to where in the motion temporally, as far as time is concerned, more restrictions coming from. So I've got this, I can create some level of rotation, but I might trip if I go too far. It's easier to rotate towards me than it is away from me. So again, there are biases built into the position that you need to understand. Now, let's just say I find some restriction, more so in this direction. So I find this restriction. Now I'm saying that I'm going direct. There's no pain that's noticeable created for the patient when I go into what we'll call direct bind. Now I've got good control, and I want to be able to use my activating forces, right? So I'm on bind, and now what I want to do is fine tune. So I can come over here, compression, I can come underneath, relative distraction, right? I can see if one of those works better. Now, I'm already in a minor torsion position, right? Or possibly a side bend position, so you can have a semantic argument about this. But what I can do here is I can, right? So I can hold here, and I can push across the pelvis, so you don't see my hand, but I can come across and slide this way. Not the easiest thing, but they are options with a good hold with lots of contact. The central portion of this hold is my leg and my torso, but I can come over here, again, some compression, relative distraction, right? This is blunt, this is not going to be clear, but whatever is going to give me more of what I want, and I can start to tune in a very purposeful fashion with different motions, right? And if I stay here and hold, we call it myofascial release. If I come on and off, we can be rhythmic about it, so we can say it's a fluid pump, we can say it's neurological. At a slow rate, we can call it inhibitory. If I'm fast, we can call it excitatory, right? We can have all kinds of discussions here. But what you get is this simple hold, right, which is very biased. It's not good for rotation of the pelvis in relation to the lumbar column on the vertical axis, so it's not good for general rotation or axial rotation. It's reasonable for side bending. You can get some reasonable compression, you can get some distraction. Flexion and extension are a little bit more biased and problematic, but you do have options. Those options all come from your central hold, having lots of contact, and then your ability to move around and the willingness to use your eyes, because if you palpate the lumbar column here, you are so contorted that you lose a lot of opportunities for motion. So this is a time where the table will do a lot of work for you, keeping the patient stable, and allow you essentially to use your eyes to get a good sense of what's going on, and also whatever physical restriction you may feel in the patient, you can relate it to the time in the motion as to where you felt it in a blunt sense. So it's not going to be specific because it's not on your fingertips. It's going to be blunt because you're going to be feeling it collectively through your forearm, through your abdomen, through your leg, and with your eyes. So it's kind of a temporal correlation. But to understand all of that allows you to now manipulate the hold in a way that has some efficacy, right? You just gotta tune in, be purposeful in how you do it as far as your activating forces are concerned. If I wanted to go in a relative indirect sense, the movements would probably look a little bit more fine. And what I'm looking for is a general sense of softness. Because I can't monitor the soft tissues that I'm curious about, I'm going to use a gross sense of softness, or a sense of softness in a very, very broad sense. So where we have some concepts that guide how we do things most of the time, there are going to be times when it's hard. So in a case like a hold like that, monitoring those tissues is not the easiest thing to do, or the tissues I may be primarily concerned with. So I can use a larger sense of softness, where whatever I'm in contact with the patient that senses some ease, I can use that. So again, just using all these concepts together to describe what's going on in a given hold and how to do it well.